Next, please. So this will be the outline of my talk. I will start with the introduction. Then we'll discuss the magnitude of the problem, what are the various kidney diseases, which population is at risk. We will then discuss the signs and symptoms, what investigations we need to do, how can we screen the patients, then what is the role of family physician, when to refer, and finally, if there is time, then we will discuss some interesting cases. So this year, the theme of World Kidney Day 2025 is, are your kidneys okay? Detect early, protect kidney health. Now, why there is so much emphasis, detect early, diagnose early, why is this? Once CKD is diagnosed, it cannot be reversed. However, we can definitely slow its progression so that the patient does not reach dialysis. For doing this, it is necessary that it is detected at an early stage. Now, you all who are not diagnosed on time and who are not detected early. Now, why detected early? Now, why is so? This is because there is complete lack of awareness in our country, including doctors and healthcare workers. Many do not have access to proper medical facilities like those staying in rural areas. Many patients are asymptomatic in the early stages. And creatinine is a poor marker of chronic kidney disease. Now, why so? I will discuss in one of my subsequent slides. What I want to highlight here is the first point, lack of awareness in our country and which we need to tackle. Okay, these are the common kidney diseases which we all come across. First of all is chronic kidney disease. The commonest cause of chronic kidney disease is diabetes all over the world. After that comes hypertension, then chronic glomerulonephritis, chronic pyelonephritis. Second is chronic kidney disease. As I said, it is not reversible, and then if not treated well, it may they normally present as proteinuria. There is edema, hyperlipidemia. In children, normally we don't do kidney biopsy because most of them have minimal change disease which doesn't require a biopsy. So we directly treat it. In adult patients, they need treatment. Next is nephritic syndrome. Nephritic and nephrotic syndrome have more or less similar features. Here also there is proteinuria, but the amount is much lesser than what is seen in nephrotic syndrome. Also in nephritic syndrome, there is hypertension and hematuria. UTIs we see in is children, adults, elderly. They are basically it is comprises of renal artery stenosis. Or there are also other renal artery stenosis is basically atherosclerosis of the renal artery. There are other conditions of the renal artery such as inflammatory, which is Takayasu's arthritis. Also, there is fibromuscular dysplasia, in which there is thickening of the renal artery, which is seen in young females. So, if you come across a young female who is hypertensive, do keep this at the back of your mind. Finally, asymptomatic urinary abnormality. What does this mean? Patient is absolutely asymptomatic. When you do a urine routine test, you find out that there is proteinuria, there are active urine sediments like RBCs, WBCs. This treatment, this condition also, it may progress to chronic kidney disease. Next. Okay, this according to the KDIGO guidelines, chronic kidney disease is defined as kidney damage or a GFR less than 60 ml per minute for at least 3 months. Structural or functional, this slide, this is the classification according to the stage of chronic kidney disease. By KDIGO guidelines. Incorporated albuminuria along with the staging of CKD. Stage 1, the GFR is more than 90. Stage 2, GFR is between 60 to 89. Stage 3, it is divided into two, 3A and 3B. 3A is when the GFR is between 45 to 59. 3B is when the GFR is between 30 to 44. Stage 4, GFR is between 15 to 30. And finally, stage 5 is when the patient needs dialysis, the GFR is less than 15. Now, on the right hand side, it is showing A1, A2, and A3. A1 is basically when the albuminuria is less than 30 milligrams per gram. A2 is albuminuria between 30 to 300. A3 is an albuminuria of more than 300 milligrams per gram. What these colors indicate is that if it is falling in that green block, that means the risk is low. Yellow means moderate or moderately increased risk. Orange is high risk and red is very high risk. The purpose of showing you this chart is that, again, if we diagnose CKD at an early stage, the risk is much lesser as compared to the later stages of chronic kidney disease. Okay, so which population is at risk? First and most important, diabetics. All over the world, at least 40 to 50% of the patients who are on dialysis, it is because of diabetes. Second is hypertension. Again, they are at high risk of developing CKD. Obesity, smokers, ischemic heart disease, patients who have family history of CKD, patients who have renal stones, they are also at risk of developing chronic kidney disease. Elderly, children, especially those who are having recurrent UTIs, and children who are having low birth weight. They have low nephron mass, therefore they are at high risk of developing chronic kidney disease. Finally, autoimmune disease. Most of the autoimmune diseases do involve the kidney. And even if they do not involve the kidney, the patients who have autoimmune diseases, they take a lot of NSAIDs and do end up having kidney problems. Okay, so in this photo, I am not, this is a glass of beer, I am not encouraging anybody to have beer. And neither am I giving any false indication that we arrange beer after my talk. Okay, so I just want to highlight the froth which you see at the top of the glass. Okay, many patients complain that they have such kind of frothy urine. Next slide. Yeah. So when they complain that there is frothy urine, this indicates that there is protein loss happening in the urine. There is proteinuria. Now here I just want to give a word of caution. If you take lot beer or lot of alcohol, this may be falsely positive. There is one more condition where this can be falsely positive. I had one patient, he said that every day early in the morning when he passes, the first urine when he passes, he has frothing. The remaining day, there is no froth that is seen. I repeatedly asked him that, what about evening, what about night? He said no. Sirf early morning when your urine pass hota hai, usme froth aata hai. He had Googled and he had already diagnosed that he has CKD. Okay, we investigated him and we found that all his investigations were normal. We nephrologists, sometimes we have to be detectives. So then it was found out that the servant cleans the commode early in the morning. There is some detergent which is left behind. So every time early in the morning when he goes to pass to urine, he sees foam. So that is one, it may be false positive because of detergent in the commode. Next slide. Okay. Clinical manifestations. Patients with chronic kidney disease, they present with periorbital edema, edema feet. First, in a kidney patient, always there is puffiness around the eyes. Whereas if there is a heart patient, they will have edema feet. If it is a liver cirrhotic patient, they will first have ascites. But it may also be, it's not necessary that always it may be true, but by and large that is the case. The second line which you are not able to see, it is frothing of urine, which I have already discussed. Next point is hematuria. Hematuria, this can happen because of stones, prostate enlargement, UTI, So whenever patient complains of hematuria, it can also happen because of glomerulonephritis. The first thing is always get an ultrasound done and also a urine routine examination, because that will tell us what it could be. It could be a mass somewhere in the kidney, in the bladder. Next symptom, polyuria. Polyuria, this can happen because of diabetes. Then it can also be because of taking diuretics, or if the patient is taking excessive water. Also, we need to keep in mind diabetes insipidus. That could be the reasons. Next is nocturia. Nocturia basically means that getting up in the night to pass urine more than once. So if it is an elderly gentleman, you should think about prostate. Nocturia can also happen if you are taking excess of water. Other thing is, it is also a clinical manifestation of chronic kidney disease, because the concentration and dilution mechanism of the kidney is disturbed, and that's why the patient has to get up at night to pass urine. Oliguria. Patients with CKD, commonest symptom is oliguria. Okay. Anorexia, nausea, vomiting. These symptoms can be because of a gastrointestinal cause, but these are also uremic symptoms. So always keep in mind that it could be chronic kidney disease which is giving rise to that. Shortness of breath. Shortness of breath patient may have because of fluid overload. It can also be because of metabolic acidosis. When kidney is the cause, of course, it can be respiratory or cardiac causes are there. Hypertension, I have already discussed that there is a bidirectional relationship. Next slide, please. Okay. Patients who have UTI, they will present with burning micturition, dysuria, frequency, pyuria. Then if the patient complains of decreased vision and he's a diabetic or a hypertensive, always get the, is there a question?
Sometimes edema on hands also like this.
Yeah. See, when there is
problem, heart sujle.
Yeah, that is true, man. See, first, it is said that it comes around the eyes. Next, it is edema. If the fluid is not restricted, if the salt is not restricted, you're going to get it all over the body. This is called as anasarca. Not just the feet, you'll get it over the hand, you'll get it over the hand, there'll be a sideways. Even in the chest, there'll be water accumulation. Okay. So decreased vision, always then keep in mind for diabetic retinopathy and hypertensive retinopathy. Anemia. Whenever you see pallor, of course, anemia has chronic kidney disease of anemia. Patients with chronic kidney disease, they have erythropoietin deficiency because erythropoietin is produced in the kidney. Therefore, the RBCs are not produced, leading to low hemoglobin. All these manifestations, they appear late. Okay, now how do we investigate these patients? CBC, this will tell us presence of low hemoglobin. BUN creatinine, that will be high. Electrolytes, that will show hyperkalemia. Calcium may be high or low. Phosphorus is high, uric acid is high. Serum proteins, that will show a low albumin level. Patients with chronic kidney disease have tertiary hyperparathyroidism because there is calcium, phosphorus and vitamin D imbalance. That's why the PTH levels are high. Lipid profile, always useful in kidney patients with CKD as well as patients with nephrotic syndrome. Then coming to urine routine. Urine routine, this will show the presence of proteinuria, this will show presence of pus cells, it will show RBCs. If it shows nitrites, that also indicates that the patient is having urine infection. Next. If the patient is a diabetic, always check fasting sugar, postprandial sugar, HbA1c. We'll come to know whether the sugars are well controlled or not. If you're suspecting UTI, always get a urine culture done. Because many a times it is found that we may just empirically give the patient some antibiotic and it may not work. So always start a patient on empirical antibiotic, but get a urine culture also along. You'll get the result in 48 to 72 hours. Many a times it is found that it is resistant to older antibiotics and only IV antibiotics are going to work. It's always better to have a urine culture in that. Okay, now how do we do quantification of proteinuria? One is with a spot urine sample, we can do a albumin to creatinine ratio or a protein to creatinine ratio. These tests are simple. They are less cumbersome for the patient because they find it very hard to keep their urine for 24 hours. But the gold standard remains 24 hours urine proteins. Okay. There are certain conditions like multiple myeloma where there is loss of BJ proteins in the urine, Benzone proteins. It is not detected by the simple urine protein test or the urine protein creatinine ratio. So, to get in a patient with suspected CKD or any other kidney problems like nephrotic syndrome, always a 24 hours urine protein is better. USG, abdomen, pelvis. This will tell us about the kidney sizes, whether the kidneys are normal, they are large in size, or they have shrunken. If the kidneys have shrunken, it is obvious the diagnosis is CKD. USG also, renal Doppler should be done when you are suspecting renal artery stenosis. If the blood pressure is not controlled, patient also has some history of ischemic heart disease, always think about that this may be renal artery stenosis, and a renal Doppler should be done. Fundoscopy. Fundoscopy to rule out diabetic retinopathy. Why fundoscopy is important? Diabetic kidney disease and diabetic retinopathy, they go hand in hand in nearly 60 to 70% of the cases. So if you want to be sure that our diagnosis is diabetic kidney disease, always get a fundoscopy done. There is correlation between the two. Not just that, you're also saving the patient from blindness. Diabetic retinopathy in the early stages is asymptomatic. If diagnosed late, patient may not get proper treatment. For the USG abdo-pelvis, I would also like to say that kidney sizes are normal in diabetics, patients who have amyloidosis, multiple myeloma, and HIV nephropathy. So, in these conditions, patient has CKD. In spite of that, the kidney sizes are massive. Okay, so if creatinine is a poor marker, then what should we do? We should calculate the eGFR. eGFR stands for estimated glomerular filtration rate. There are many formulas for it, Cockcroft-Gault, MDRD, CKD, EPI. Cockcroft-Gault, this formula turns out to be the simplest formula anybody can use in their clinic to calculate the glomerular filtration rate. It is 140 minus age into weight divided by creatinine into 72. If it is a female, multiply it by 0.86. The other two formulas, they are very complicated. You need a calculator. Without that, it is not possible to do. Even for us, we find it difficult. Although the KDIGO guideline says that CKD EPI equation should be used for calculation of eGFR. Next. Now, as I said, the clinical manifestations appear late. So, how do we detect it? The answer is screening high-risk patients. How do we screen them? Screening of these high-risk patients should be done regularly every 6 months. What tests to be done? Two simple tests. One is serum creatinine, which costs the other one is urine microalbumin to creatinine ratio, which will cost 500 rupees. The total cost is 350 rupees. The total cost comes to 500 rupees once in 6 months, or if you say only 1000 rupees in a year. Is it really too much? Some people think it is too much. But in the next slide, you will find the answer. Next 2 slides. See, I always tell my patients, prevention is better than cure. Just like we get our car serviced regularly every 6 months. Why? Because we want smooth running of the car. We spend almost 10 to 12,000 for one service. Similarly, for smooth running of our body, it is necessary that we spend a small amount of money in screening such patients who are at high risk. Next. This chart will tell you that what are the expenses if a patient goes on dialysis. If the patient goes on hemodialysis, the cost is approximately 25,000 per month. This is just the, I've taken the minimum cost, maybe like not a very expensive center. If the patient selects peritoneal dialysis, the cost comes to 40 to 50,000 per month. And if the patient goes for renal transplant, the cost is nothing less than 15 lakhs for the first year, and then every month the patient has to spend 25 to 35,000 per month for the medicines. So looking at all this, I think it is worth that we do screening and prevent the patient from reaching this stage. These things are really expensive, and hence the real need is to prevent the patient reaching end stage renal disease. Next. Okay. So for healthy patients, an annual health checkup is a must for patients who are above 40 years of age. They must get their blood pressure also checked once a year. Out of these, the high-risk population can be identified.
Annual checkup means urine checkup?
No, just a complete health checkup. Next. Okay. What are the lifestyle changes and preventive measures? Control sugar, control blood pressure, control lipids wherever applicable. Stop smoking, exercise regularly, reduce weight. And the most important thing, avoid NSAIDs, painkillers, contrast agents, and aminoglycosides. Advice for CKD patients. Patients who are at CKD stage 1 to 2, 0.0 grams per kg per day. Stage 3 to 4 is 0.6 grams per kg per day. So the role of family physician. A family physician. Now, when should you do nephrolosis? When the eGFR comes to less than 60 per minute, then an early referral can also be done if the creatinine is borderline. This helps in establishing the etiology, and if there is any treatable cause, we can treat and correct it. Then next, when there is proteinuria or albuminuria, then UTIs. What kind of UTIs you should prefer? If a patient is having a recurrent UTI, it is normally seen in diabetics. You give antibiotics, patient is fine. After a few days, again the same complaints of UTI. Such patients. Second case, resistant UTI. You have given the appropriate antibiotic. In spite of that, there is no response. We need to work up the patient further. Asymptomatic UTI. Many patients have no symptoms, but there are high number of pus cells in the urine. Whether or not to treat, it's a very tricky situation. Complicated UTI is basically means that if there is some structural abnormality, say there is a kidney stone, there is a prostate enlargement, or if the patient is immunocompromised, like a cancer patient or HIV positive patient, if it's a kidney transplant patient, or if there is a polyskeletal patient, such patients fall under the complicated UTI criteria. Then uncontrolled hypertension. If BP is not well controlled, it is a high risk for developing chronic kidney disease. Always refer here. Diabetic patients form the maximum number of CKD patients all over the world. So, if the patient has diabetic kidney disease, please refer. Finally, if you want the patient to be counseled for dialysis or kidney transplant, then you should refer. Actually, here the word I'm using, counseling, that's a very mild word. Rather, I should say that if you want to scare the patient, that actually happens in my practice. That if I tell them, if you don't follow your treatment and your precautions properly, you're going to end up in dialysis. At least it works for 50 to 60% of the patients. It may not work for all. People don't understand, don't listen. But if you scare them, you're going to go on dialysis. It doesn't. Okay, let's have some interesting cases. We have time for cases, right? Yeah. Okay, thank you. So this is case 1, a 47-year-old male diabetic since 6 years, poorly controlled. Also hypertensive for 3 years, which is well controlled on 2 drugs. He has developed edema feet, puffiness of face. HbA1c is 9.5, creatinine is 1.7. Urine routine, it shows protein 2 plus, pulses 3 to 4. There are no RBCs. 24 hours urine quantification, it shows 1.9 grams per day of protein loss. Fundus shows non-proliferative diabetic retinopathy. So what do you think the patient is having?
Diabetic
Next. Yes, absolutely correct. The answer is very, the diagnosis is very obvious. Yeah, next one please. Okay. This is a 56-year-old male. He's diabetic since 3 years, which is well controlled on 2 oral hypoglycemic agents. Hypertensive for 5 years. In spite of 4 antihypertensives, this patient's blood pressure is 170 by 100. He has history of ischemic heart disease. Angioplasty was done and 2 stents were put 3 years back. He is complaining of shortness of breath, edema feet, creatinine is 4. Protein is trace in the urine, pulses are 3 to 4, RBCs are 4 to 5. 24 hours urine protein, not much, 300 milligrams per day. On fundus, there is no diabetic retinopathy. He does have grade 2 hypertensive retinopathy. His USG was done, kidney sizes, it was, right kidney was 9.7, the left kidney was 8.2 centimeters. Next one. He got admitted. After the day, the creatinine increased to 5.3. Now, because the blood pressure was not well controlled, in spite of giving 4 drugs, we got a renal Doppler done, and that was suggestive of bilateral renal artery stenosis. Angiography was done. The left renal artery was 90% stenosed, the right renal artery was 70% stenosed. He underwent renal angioplasty, and after that, the creatinine came down to 1.9. So this is a classical case of
non-diabetic.
Yeah,
non-diabetic
kidney disease and having renal artery stenosis.
So you can probably reverse a little bit the condition.
Yes.
If the
Yes,
cause
it
is
can.
treatable.
It is treated.
Yes.
Yeah. Okay. Third case, 45-year-old female, diabetic for 2 years, well controlled, not a hypertensive. She has a gradual onset of edema, and later on it became anasarca, that means generalized edema all over. Creatinine is 1. Urine routine shows protein of 4 plus, pus cells 10 to 12, no RBCs. 24 hours urine protein very high, 8 grams per day. Fundus normal. So again here we are dealing with something which is non-diabetic. We got a kidney biopsy done and it turned out to be membranous nephropathy. Next. Okay, this is a 60-year-old female, diabetic, hypertensive. She was complaining of mild evening fever and milky urine. Creatinine normal 0.9. On urine only 100 pus cells, no other abnormalities. Urine culture did not show any growth. She didn't receive any antibiotics before doing the urine culture. So, ultrasound, it showed right kidney was 10.5 and left kidney was 12 centimeters, slightly enlarged. So we thought a fungal infection. We did a urine for fungal culture, that was negative. Next, we thought it could be tuberculosis. We got a urine for a mycobacterium tuberculosis by RT-PCR. It turned out to be positive. The case of renal cox.
Can it be hydronephrosis also secondary to something?
Yeah, hydronephrosis can be because of a stone. It can be because of some mass in the bladder. If there is any kind of bladder outlet obstruction, that can give rise to hydronephrosis.
Because her kidney size was slightly enlarged.
Yeah, but it was just kidney. That's because of the cox.
Pox.
45-year-old male. He had complaints of occasionally having reddish urine. There was no edema feet, no diabetic, not a diabetic, not a hypertensive. Creatinine 1. Urine had protein 2 plus, RBCs 50 to 55, pus 1 to 2. On ultrasound, on the right kidney, there was a small non-obstructive calculus of 3.5 millimeters in the lower pole. Could this calculus be the cause of the reddish urine? I cannot deny that. It could be. But protein 2 plus, that is not matching. So we got a 24 hours urine protein done that turned out to be 1.9 grams per day. So we did next we did a kidney biopsy. It turned out to be IgA nephropathy.
This is one of the commonest nephropathies, IgA nephropathy.
In the world. Also. Yeah. Okay. Next case. This is 30-year-old female. Generalized weakness since 1 month. She had pallor. The blood pressure was 140 by 90. She was given oral iron supplements. After 2 weeks, she started having shortness of breath. There was no edema feed, no periorbital puffiness. Next slide. Hemoglobin was 8. WBC counts normal, platelets normal. Creatinine was 11. The urine routine, proteins 2 plus, RBCs 10 to 12, pus cells 5 to 6. Ultrasound showed normal kidney sizes. On 24 hours urine protein, it was 1.1 grams per day. We were suspecting a rapidly progressive glomerulonephritis, crescentic nephritis for this patient. Next. And it actually turned out to be that. Her anti-GBM antibodies were high. Kidney biopsy showed crescentic glomerulonephritis. So this is the case of RPGA, rapidly progressive
These
glomerulonephritis.
anti-GM antibodies are pathogenic of this. Means without doing a kidney biopsy, if this test is positive, can we do the diagnosis of that?
Yes, we can make a diagnosis, but kidney biopsy is necessary in these patients. We sometimes start the treatment even before doing the kidney biopsy, but we must do a kidney biopsy because kidney biopsy will tell us the extent of damage in the kidney. How extensive are if there are crescents, what kind of crescents, whether they are fibrous crescents or they are cellular crescents. Fibrous crescents don't have a good prognosis because it means there is fibrosis which is happening. So, to know the extent of damage and to know the prognosis, kidney biopsy is important. Okay, this is my last case. 40-year-old male. He was absolutely asymptomatic. He underwent a health checkup in his office, and blood pressure was found to be 160 by 90. Creatinine was 1.3. On urine routine, there was proteinuria 1 plus, RBCs 10 to 12, pus cells 0 to 2. Ultrasound showed normal kidney sizes. So he was started on antihypertensives and then referred to nephrologists. On further workup, 24 hours urine protein was 700 milligrams per day. He didn't have any history of diabetes or hypertension in his family. So we started him on anti-proteinuric measures. Now normally if the 24 hours urine protein is less than 1 gram per day, usually we don't biopsy such kind of patients. So we advise that he should take anti-proteinuric measures, he should be under observation, he may need a kidney biopsy later on. After 3 months, blood pressure was controlled, creatinine increased slightly, 1.5, but the proteinuria, it simply doubled. It was 1,500 mg per day. So we did a kidney biopsy that turned out to be membranoproliferative glomerulonephritis. Okay, so my take-home message is prevention and precaution is the best cure. Screening of patients who are at risk of kidney disease is a must today. And early referral to nephrologist is always helpful. Thank you so much.
In the last case, it was the kidney disease which caused hypertension. Yes. Correct?
But what precaution to be taken? Kidney disease नहीं होने के लिए.
Well, if you don't have diabetes, if you don't have blood pressure, then you can just say, thank God that 2 major risk factors are not there. Drink lots of water, at least 2.5 to 3 liters of water in a day. Don't take too much of salt, like achar, papad, all these things are very. Avoid high
Salt.
food. Yeah, so avoid high food which is high in salt content. Do regular exercise, some kind of
sugar will do with no diabetes, sugar? No diabetes.
Yeah, you
Then
will.
sugar can.
No, so that's what I said. If you don't have diabetes, you don't have blood pressure,
Yeah.
then the first thing you should do is say thank God.
Thank God. Yeah. Correct.
But you don't go overboard with the sugar.
Sorry.
Yeah.
Sugar also.
That's-
Sugar also you don't go overboard.
Don't go overboard.
Overboard.
Absolutely.
Just take it in a
Moderate amount is
Limited.
okay.
Moderate
Yeah,
amount is
moderate
okay.
amount is fine.
Sir,
and
what about-
fruits one can take if one doesn't have diabetes.
Yeah, no restriction. On fruit, if you don't have diabetes, there is no restriction.
So relation of age
Mhm.
and EGFR.
Yes. The EGFR formula itself, it takes into account the weight and the age of the patient. So, even if your creatinine is 1, as the age progresses, your EGFR goes down. That's how the kidneys function. So, it is related to age, it is related to
So same precaution should be taken.
yes.
Get hold of. Thank you, sir. Wonderful, sir. Very good.
Wonderful.
Thank you.
Thank you,
sir.
thank you so much.
Very nice. Easy to understand.
Thank you, Dr. SUYASH Sharma, sir, for giving us this interactive talk. And we would, with the permission of Madam Kavita Vishwakarma, go on to myself, Dr. Sandip Bhurke. Right now, we are live streaming on YouTube and on Instagram, and all over the world, people are seeing us, including the big audience which is in front of us. So I will be talking only about the World Kidney Day awareness campaign which is going on in the world. So it is on the second Thursday of every year, and this year it is on 13th of March, that is tomorrow. So today we are having the awareness talk for general doctors, and tomorrow will be the awareness talk for the general public, relatives, patients and hospital staff. Right now we are inside the Brahmakumari Hospital, BSES MG Hospital in Andheri, which is in Mumbai, India. And my assistant will help me to show us the posters which have been, he is Ayush. So we will be seeing the posters which have been sent by the International Foundation of the World Kidney Day. The first thing would be the logo. So these have various outlines. This is red outline, that is yellow outline. World Kidney Day logo. You can also print them with the year. They are available on the website of the World Kidney Day organization. So these placards have been made by printing them on a stiffer, thicker paper and then sticking it with wooden skewer sticks and using sticking plasters, sticking tape. So it is not going to break or being blown away when you are holding. So these are the logos of the World Kidney Day. Second is the theme of the World Kidney Day of this time, 2025. Are your kidneys okay? And online also there is a quiz, a QR code. You can go on to that, and then it is asking you simple questions about the diseases and morbidities which you have, like diabetes, hypertension. Are you fit enough? Are you drinking water enough? Whether there is alcohol intake, whether there is smoking, etc., etc. And then they are telling you about the possible probability of you getting a kidney disease. So this quiz is open for anybody and everybody. They can go onto the website of the World Kidney Day 2025 campaign and take the quiz. This is for people who are more like social workers and want to make a change. They can also go onto the World Kidney Day website and sign the petition for global change in kidney care. So this is going to go to all the governments of the world and to give more resources for kidney detection, kidney screening and kidney prevention.
Kidney shirt is also there.
Yes. As Madam rightly said, you can print the t-shirts as part of the campaign. The logo and the theme is there in this, and we will have the t-shirts being distributed by various NGOs. Then these are the various colored names of the World Kidney Day from the website. Then these are the golden rules. So the golden rules, number 1, keep fit, eat healthy, check your blood sugars, check your blood pressure, stay hydrated, don't smoke, reduce alcohol intake, avoid taking painkillers, and check your creatinine. Then there are cartoons of the kidney for kids because they would not be able to read the sentences. So kids can take this in their school and create awareness campaigns, awareness walks.
So one more precaution, I think the urine for very long time.
Agreed.
So one more clarification, sorry, yeah. Yeah. See, how much is the total amount of blood which goes to the kidney in 24 hours?
Something around 625 liters.
So out of that, in a normal person, about 1.5 to 2 liters of urine is formed.
Yeah.
So a normal person, a bladder has a normal capacity of how much, sir?
250.
250. 250 to 300 maybe. So a normal person in a day should pass urine 7 to 8 times.
Yes. You should take at least 8 to 10 glasses of water in a day, and at least 7 to 8 times you should pass.
But some patients are telling that they have continuously urine.
Sorry.
More than 7 to 8 continuously they are going.
Means they have got more frequency of urine.
Yeah. First of all, rule out UTI. The second thing is find out how much is the quantity. Sometimes there may be some bladder dysfunction, so then they need to be referred to a urologist.
Thank you, sir.
Thank you.
Thank you. Sorry.
It's all right. So my talk was regarding the common drugs which are causing AKI. So I'll wrap this up very quickly. Whenever I get a nephrology consult for a patient who's an inpatient, I will first of all review the drug chart. It is very important to review the drug chart of the patient because so many drugs which are commonly used has a potential of damaging our kidney. So जो सबसे common है वो है pain killers, Combiflam, Brufen, Nimesulide, Voveron, Enzoflam, Etodolac. तो सारी की सारी जो दवाइयाँ हैं they are harmful for the kidneys. So we should avoid painkillers. I tell patients take a Dolo instead, take a paracetamol.
But sometimes it is necessary when pain is too much.
Yes, so if pain is too much, we can use Ultracet. उसके अलावा we can use amitriptyline, pregabalin, gabapentin. They are not like the usual painkillers, but they work very well. The other thing is I tell the patients go to the root cause of the pain. अगर किसी को headache हो रहा है, accelerated hypertension की वजह से headache हो रहा है, और हम पेन किलर्स खा रहे हैं, we are actually aggravating the problem. The painkiller, the NSAIDs are going to cause salt retention, cause more headache. So instead, find the cause. If it is migraine, take the prophylaxis. So discourage your patients to have antacids like PPIs specifically, omeprazole, rabeprazole, esomeprazole, pantoprazole, all of them are not that innocuous. उसके अलावा when the patient is admitted, avoid antibiotics like aminoglycosides, colistin. Even ciprofloxacin sometimes can cause AIN. Even AIN can be acute interstitial nephritis, which is an allergic reaction in the kidney. With cephalosporin, with amoxicillin, penicillin group. So virtually any antibiotic can cause AIN. So we have to review the drug chart. Also we have to see that there are vulnerable population, the elderly, the diabetics, the hypertensives, volume depleted patients, patients with sepsis, with multiple comorbidities. We have to be very careful in these patients. Apart from that, we have to see that the cardiac drugs like ACE inhibitors, ARBs, dapagliflozin, These are the drugs which can cause pre-renalia in a patient who is dehydrated. So every time, so there is something called the sick day rule. अगर patient आपका telma पे है, so you'll tell the patient कि जिस दिन आपको sickness है, acute sickness like vomiting, nausea, diarrhea, fever, do not take telmisartan. Do not take dapagliflozin. जब आपका illness का period over हो जाए, you restart it. So we have to be like very careful when it comes to drugs, especially females. में painkillers are the third most common cause of kidney failure, specifically in women. And अभी मेरी OPD में 2 दिन पहले एक patient आई थी. She said, I don't feel nice if I don't take enzoflam. Creatinine was 4. So I had a hard time explaining him. Still, because I get tired, I have to take it. So she was kind of dependent. So because patient don't come to us, patient comes to you. सबसे पहले, you are the first point of contact. So you have to tell patients that they have to be vigilant on taking any OTC drugs. उसके अलावा, I mean, I know that it hurts sentiments, but alternate drugs do not. They are known to cause kidney injury. They are a very prominent cause of kidney injury, especially in India. Ayurvedic drugs. So there are 2 types of drugs in Ayurveda. One is Siddha medication, जिसमें heavy metals use होते हैं. So all those heavy metals harm the kidney. Because they are the toxins that are removed by the kidneys. Another thing is herbal medication. Herbal medication, Chinese herbs, Indian herbs, they are known to cause kidney injury. हमने देखा हमारा patient stable चल रहा होता है, then he goes to some Ayurvedic practitioner and he comes back in a very bad state. Every month we see such patients. It is very unfortunate because often we cannot offer them anything, and sometimes they need dialysis. And I had a patient, he had UTI, small kidneys, recovered, creatinine came down to 2, then suddenly creatinine went to 5. I was like, what has happened to this patient? And on very deep probing, the bahu of the family told that मेरा नाम मत लीजिएगा, but she was taking some सुबह कुछ juice or कुछ herbal medication. Now, I mean, it is very disappointing for us also. It is sad. Then I told the patient कि अभी कोई अमृत बोल के भी कोई तुमको कोई दवाई देगा कि अमृत है, उसको भी नहीं लेना है. So see, it's a truth that people take Ayurvedic medications, but if your patient is on an Ayurvedic medication, tell him to check his creatinine. At least ये चीज डिस्पेल करना बहुत जरूरी है मिथ कि आयुर्वेदिक दवाओं का साइड इफेक्ट नहीं होता है. उनके साइड इफेक्ट्स होते हैं लिवर टॉक्सिसिटी, किडनी टॉक्सिसिटी, which is often irreversible. So that's about it. Thank you.
Madam, one more thing is there, that if they are having some swelling in the body, then we have to give them something to reduce the swelling. Then there are certain drugs which are available. For example, seropeptidase. Is it safer in kidney?
Yeah, peptidase you can use, but without the pain.
Yeah, without the pain.
Yes,
Other
yes.
thing is, if we have to use some anti-inflammatory drugs, are steroids slightly safer than
Yes.
NSAIDs?
Yes, definitely. So what we do is in our set of patients, if a little less dose of steroid is always better than giving NSAIDs. Obviously, you have to monitor. You cannot give them for long term, but a short course of controlled monitor steroids is definitely better than giving NSAIDs. So I have an immunologist friend who I used to refer for my patients for arthritis. So he'll put them on a very low dose of methyl medrol 8 mg or 16 mg and then taper it down to maybe 2
We can
mg.
use this ordinary prednisolone
Yes,
also.
yes, definitely it is better, but steroids also have side effects. So we have to tell them, we have to tell patient to not abuse it, we have to monitor, and we have to give as short a course as possible.
Other thing you said, you can use pregabalin, or
Yes.
you can use even tricyclic antidepressants, or you can use duloxetine.
Yes.
Then what is the recommended dose? Because pregabalin we use for neuropathic pain in diabetics especially. So we go to a very high dose of say 75 milligrams, because such people when they get neuropathic pain, they are not able to sleep in the night. So that is why they come to us to give us certain safer drugs which they can take in the night for at least having a good night's sleep.
Yes.
So what is the dose which you would recommend of these things which you have recommended as alternative to pain therapy, and how long they can take?
So first thing, the pain, I would always like to see if my patient is anemic, if he is hypocalcemic, if he has low vitamin D, if he has low vitamin B12. So these are, if he has, thyroid issues, these are the factors which are reversible. We should always replenish these. Then coming to pregabalin, we see that, pregabalin accumulates and it can cause excessive drowsiness in patients of CKD. In advanced CKD, if it is given, then it can even cause hallucination, delusions, and excessive somnolences. So we reduce the dose. So what I do is I will start with 25 milligram or daily, and I will tell the patient this is a very low dose, and we will step this up depending on your tolerance. So you take 25 alternate day, and see if you feel that you are really drowsy. Start with 25 alternate day and then make it. Usually the symptoms are initially very severe, and as patient continues to take them, he develops a tolerance for symptoms. So I, depending on the patient tolerance, will give 25 H's or 25 alternate day. If he is tolerating well, I go up to 50. And that is the maximum that I use. Dr. Bhurke, what about you?
There are preparations available with 25 or 50 with some B complex, or alone are they
Alone.
available? Alone they are
Yes,
available.
yes. So 25 is alone, it's prevalent, we get it. And in dialysis patients, we will never go beyond 25 milligram HS. And then also we'll ask the relatives to monitor the patient, that you have to see how is he doing, and then we can alter the dose as per the tolerance.
Now, other thing was that there are people who are suffering from, say, chronic kidney disease, who can get herpes, especially the elderly people. In that cases, we have to give either acyclovir or samcyclovir. Other thing is that such patients, they can get other type of infections like fungal infections, skin infections. So how do we go about giving them those medicines?
So antifungals can be given, but in reduced dosage. And
So which among the antifungals we can give? We can give fluconazole.
yes, I think voriconazole IV is something that we cannot give.
Yeah.
Apart from that, all the antifungals can be given with dose modification. So the dose modification varies, but we've been using if the patient is admitted, we use 400 milligram stat and 200 mg IV
I'm
ODs.
talking about basically such patients who are on OPD basis with
So
us.
150 ODs for 2 weeks, maybe 150.
Fluconazole we can
yes,
give daily
we
for
can-
2 weeks or 3 weeks.
Yes, but depending on, if you are treating an acute infection, what I'll do is that I'll give a short course of daily fluconazole, and then I will put him on a twice per weekly kind of a regime, which is like a maintenance if he needs it for a
longer
term.
period, yeah. Twice a week you can give.
Yes.
Other thing is that we can use the creams, we can use no problem.
Yes.
The creams, there is no problem, we can give them any.
Yes.
Same thing is it with the NSAID creams that we can use?
We can use them. So I always tell my patients, rather than popping a diclofenac, it is better that you use Volini.
Yeah.
So there is 5 to 10% systemic absorption, but it is not very significant. If the patient has a lot of pain, we give patches also. We can give fentanyl patches, but we can give something like Dynapar or Volini, which is safe. Yeah.
Same with acyclovir, we can give the full dose,
No,
or
we have to reduce the dose of acyclovir.
because in herpes zoster we have to give
Yes.
nearly 800 milligrams 5 times a day.
So we give 400 TDS to our patients, and the dose comes down as the GFR declines.
Okay. So as the GFR declines, we have to
Yeah,
give less.
we have.
But then can we give it for a longer period, or should we give only for 7 days?
So it depends on the response, sir. If it is a disseminated kind of herpes,
Yeah.
obviously patient will need so it needs to be tailored as per the patient. But usually we give it for 5 to 7 days only. If it is a zoster or something, but if it is zoster ophthalmicus disseminated, then
We have to give
obviously-
steroids also along
yes,
with it.
then you will need a longer course.
Longer course, and probably we need steroids for this. Thank you, ma'am.
Thank you so much.
So request some of the audience to hold the posters for World Kidney Day.
Yeah.
Madam will take a photo for the Indian Society of Nephrology.
Yes.
Yeah, yeah.
Any random you can pick up.
Okay.
आप ही ले दो ना एक फोटो आप ले दो. I will check your creatinine in this and so
First one, please.
आधे हो गए अच्छा.
I will take this back. It's all okay.
एक बार ये दोनों बार किडनी लेके ना ये check your creatinine. Check your creatinine.
What will you are?
You are.
थोडा आगे आ जाइए. एक तुम्ही डॉक्टर ते या ना एका लाईन मध्ये.
Okay, fine.
नहीं थोड़ा सा
पीछे जाएगा. हाँ,
इनके हाँ
ठीक है,
एक
ये
लाइन में
लाइन
थोड़ा.
तो मैं इसके ऊपर भी जा सकते हैं.
हाँ कुछ लोग ऊपर चले जाओ तो बेटर हो जाएगा.
लेकिन ये ऐसा ना हो इसको पैर नहीं.
एक सेकेंड.
ठीक है.
नहीं थोड़ा आप लोग इधर आ जाइए. आप तीनों थोड़ा और हाँ अभी आप बाकी पीछे वाले थोड़े इनके एक लाइन में आइए ना. मतलब बुरके सर तुम्ही थोडं इकडे या ना. हाँ डॉक्टर कविता मैम जरा. हाँ आपने उल्टा पकड़ा है वो. नहीं उसको पोस्टर तो दूसरा वाला.
Left hand
हाँ
side.
लेफ्ट. हाँ
ऐसा ऐसा.
असं
हाँ.
सरळ कर.
हाँ एक सेकेंड. हाँ अभी जो संजय सर बोल रहे थे वैसा.
I think
Okay.
everybody should give one slogan right now. So always give a loud slogan in the one go only. So the slogan will be 1, 2, 3.
Are your kidneys okay?
Yes.
Yes.
My
Yes.
kidneys
Yes.
are okay
My
because
kidneys
I
are
keep
okay.
regularly checking up my kidneys profile. Thank you.
God bless you.
Thank you, sir.
Thank you. Thank you.
I'll take a photo. as usual.
Which message is
एक मिनट आ रहे हो.
there?